standing or embeddedness for this type of work in terms of political economy in the region. Nearly all the political economy of welfare is written by outsiders outside the region. And so this is, I think, one of the biggest issues for actually delivering UHC, is having that wide expertise. And I think maybe Fadi will talk about that a bit more later. Next slide, please. The other issue I think that's come out, and this is work from our team, from the team in terms of individual books and large pieces, is that the Western medical paradigm has dominated a lot of the NCD thinking. It's all about being about care rather than embeddedness in the political economy and the new therapeutic geographies. As Omar Dawachi wrote about in Ungovernable Life, the loss of human capital from the region means that in terms of delivering NCD care, everybody is always on the back foot. And indeed, in bringing it up to the modern day, Ghassan Abu Sitta has written an absolutely superb piece looking at the impact of COVID-19 and also the siege within Gaza in the age of Corona. And what that talks to is this issue of knowledge subjugation around data. So when we talk about outcomes across the region, some places are having decent registries, but many places it's very hard to tell what the true outcomes are, and particularly again for vulnerable populations or those populations who have been undergone forced migration and displacement. Next slide, please. And this is the last one, and the one I want to focus on most of all. I think one of the things we've been looking at is how to overcome knowledge subjugation across the region generally. And when we talk about knowledge subjugation, we're talking here about outsiders determining the narrative. In other words, Westerners writing about MENA problems and solutions to MENA problems. We're talking about knowledge subjugation in the sense that a lot of the information that's collected, either quantitative or qualitative, has very, I would use the word dangerous political or social impacts. And so producing that data and publishing it is often extremely difficult. But also, finally, how the data is framed in terms of improving policy. And particularly when we look at the health economics and the underlying foundations for delivering universal health coverage, what we see is problems at each level. We see lack of capacity and the ability to carry out health economic or political economy studies. And we also see significant issues anyway in getting that data published and then actually influencing policymakers. So there's a really, really big gap there in the evidence to policy. And so, Mike, at that point, I'll draw that to a conclusion and just say that most of the publications you see here are on our website and can be easily accessed and read. Thank you very much.
Thank you very much, Richard, and particularly for being so concise, but I think delivering a very powerful message. I'm sure there will be comments or questions, and I'm sure you would be happy to receive those either direct to you after this meeting or through the chat. So please, people, do reach out, put your questions or comments, and we come to some discussion later. But we will continue to move on so that we can discuss all the topics together. So it's a pleasure to introduce Dr. Mohanad Al-Mansour, who's the Executive Director of the Eastern Mediterranean Public Health Network, to give us our next talk, which will be also for 10 minutes. And if it's looking like it will be too long, I will interrupt again, I'm afraid. So please go ahead, Dr. Al-Mansour.
Dr. Al-Mansour, you should just be able to enable yourself on stage if you enable your camera and audio.
Dr. Mohanad.
So Fern, if we're struggling with Dr. Al-Mansour, I can see that Dr. Tasneem Attacher is with us. Do we want to proceed to get Dr. Tasneem's presentation?
Yep, that'd be wonderful.
Hello, do you hear me now, please?
Okay. Oh. Thank you, Dr. Mansour. Yes, we hear you now. Please go ahead with your talk.
I think we've lost Dr. Mohanad again. Perhaps we, if we move on to Dr. Tasneem.
Dr. Tasneem, thank you for. I hope you're. We're not ambushing you too much, Dr. Tasneem. Thank you very much. So, Dr. Tasneem is WHO Health Emergency Coordinator for Central Asia, and is a policy fellow at the Centre for Science and Policy in University of Cambridge. And it's a pleasure to have your talk, Dr. Tasneem. So please go ahead.
Thank you very much. So for the last few months at the University of Cambridge, as being a policy fellow, we have been discussing resilience, and we have been coming into different definitions of how we can define resilience. Especially in my work as coordinating the emergency program in Central Asia, we realized that when it comes to advancing universal health coverage, it is much about how we are also advancing countries' resilience. So in this presentation, I will just take you through actions that we taken over, not only over this year, but also informed with number of institutional capacity building actions to advance universal health coverage with emergency response and also strengthening health system resilience. Next slide, please. So Central Asia is basically composed of 5 countries, and here namely Kazakhstan, Kyrgyzstan, Uzbekistan, Tajikistan, and Turkmenistan. And in these 5 countries, they have been reporting more than 351 cases since March 2020. And these cases have been reported from Kyrgyzstan, Uzbekistan, Tajikistan, and Kazakhstan. And I'm trying in this slide just to provide an overview about the number of cases per each country, but also what we need here to focus on, and that it's not only about the number of cases, but also we need to show these numbers in reference to the population number. And we tried also here to show you over time the cumulative incidence. So we can see across Central Asia, there is a decrease of cumulative incidence of cases and deaths. So how did we work on contributing to health system resilience across these 5 countries? What we have been doing was sort of building bridges of trust and cooperation among countries that are sharing borders, sharing the same challenges, and also sharing history, as these countries have been part of the Soviet Union, so they inherited a lot of the previous system. To take this further, we have been working a lot on strengthening capacity building, but capacity building was not only about strengthening human resources for health, but also strengthening the capacity of network, bringing these countries together. For example, we have been working on a network for international health regulation focal point between these countries who have been working on sharing information, sharing best practices, and also talking about what I like to call the brilliant failures, as we need to learn also from the failures and the challenges that we are facing. Second, we have been working on coordination. Coordination was the core of this work through coordination of assessment, coordination of studies, coordination of planning, and implementation. And with this, we were ensuring the effective use of limited resources, especially that we are talking about countries with limited income and countries with limited resources, fighting against a number of challenges, including the fragmentation. Last but not least, we were working on advocacy. And this has been taking a lot of our work and time, as advocacy had been addressed at several levels, going to parliament, to policymakers, and addressing each with the provided evidence to ensure that we are making the required change on the ground. Next slide, please. To summarize the main action that have been taken through the COVID response, countries have been working together to develop countries' preparedness and response plans. This was important to highlight as countries coming together to articulate their actions. And with this, again, there was a lot of effective use of resources. Countries have been sharing expertise and also sharing means of how to translate the global guidance tailored to the national context. We took these plans forward and we created what is called an operational plan. And this plan has been having a lot of emphasis, again, on capacity building, on community mobilization, and also on the provision of essential supplies and tools. Community participation in Central Asia was of great importance. So equally as the government's actions were important to address COVID, the actions of the community was equally important, especially in these countries where in the same country we will have people from 3 or 4 nationalities. So in Kyrgyzstan, on the borders, we have Kyrgyz and Uzbeks, Kyrgyz and Tajiks, Kyrgyz and Kazakhs. So we can say that these at some point, maybe these borders are on the map, but for the community, these borders are artificial. So working with these communities collectively had a great importance. Moreover, we have been working on bringing international expertise on the ground, addressing and bringing international experience. We have been working on cross-cutting issues like gender-based violence and addressing a number of topics, including migrants, refugees, health, and vulnerable population. Moreover, we have been working on advocacy for repurposing of health facilities and repurposing of health workers, and this had a great importance for the provision of essential, mainly at primary healthcare level, contributing to universal health coverage. Last but not least, we have been working together in reviewing our actions using what is called the intra-action review that has been a tool developed by WHO given to countries to review their actions through the COVID response and inform the update and review of specific countries' plans. Next slide, please. What were the challenges? Especially in the time of July, August, when the cases were high, and even before, countries opted to close the borders, to introduce several aspects of lockdown. This affected the health system. Moreover, the health system was overwhelmed with the high number of cases, keeping in mind that the health system was already fragile and under a lot of pressure. COVID came and increased this pressure. When it comes to primary healthcare and essential healthcare services, there was some sort of interruption, and then again, this was a challenge for the health system. And moreover, there was issues with accessing information, accessing of information about the availability of the service, access of information about where the service is being distributed, that can be the reason for hindering the ongoing provision of essential health services. Next slide, please. And with this, I want to end my presentation by highlighting some lessons learned from the experience of Central Asian countries. First, the government leadership. The government leadership is number one of importance to advancing policies and putting the required resources in approving the repurposing of health facilities and also ensuring the collaboration between countries. Moreover, the importance of the timely and efficient and effective technical support and bringing the international experience to optimize the response. Moreover, the importance of partnership. As I started this presentation with mentioning bridges of trust, these bridges of trust have been providing the impact during COVID. As we worked on establishing these bridges for the years before, we're bringing these countries to work together on emergency preparedness, applying the international health regulation framework. Moreover, access to information, transparency, and the two-way of sharing of information is important to inform decisions and also to inform effective distribution of resources. Last but not least, the articulation of a common vision, articulation of a common goal to ensure that we are all working to a common cause was important for the success of all of these interventions. And this would bring me to my last slide. Thanking you all and happy to take questions. Over to you, dear Mike.
Thank you very much, Dr. Tasneem. And again, thank you for stepping in quickly and keeping pretty much to time. So we'll take the questions at the end, and please put your, for the participants, please add your questions or comments in the chat as well. So I think there were several themes coming up in your talk there that were emerging, at least some of the breakout groups I witnessed yesterday. So I'm sure we'll come back to some of those themes. But I'd now like to pass back to Dr. Mohamed Al-Mansour. And please, Dr. Al-Mansour, if you'd just give us your 10-minute talk. It's a pleasure to let you participate in this. So please, over to you.
Thank you for giving me this opportunity. You know, I am here to talk about advancing universal health coverage in the Middle East and North Africa, the role of research. So next, please. And no, I ask you, I sent you another was the one that the updated one. Hello.
Fern, do you have another and updated in your version of the presentation, please?
That's right. They should be in the folder. So if we could just get those uploaded. They're in the folder.
Okay.
The drive. Sorry about that.
Yeah, sorry. It's a little bit more updated.
Okay. This is the one, Dr. Mohamed?
Can we go next slide, if you please, just to look at? No, this is the old one. This is the old one. You know, I just did send the presentation, and you confirmed receiving it and updating it.
Okay.
So yeah, maybe yeah. Sorry, I feel that I am guilty in this gathering. You know, I keep accusing Edic with.
Don't worry, Dr. Al-Mansour.
Yeah, I am so sorry for that. Yeah.
Don't worry, Fern. Are we going to be able to get the updated presentation, or might we have to ask Dr. Al-Mansour to work with his older one? With our apologies.
Yeah. Can I share my presentation from my side, or it should be controlled by your side?
They're just coming now, Dr. Mohamed. They're just coming, so we'll just get them up in a second.
Yeah.
Okay.
Can he share it from his side, Fern? Will it be easy?
I don't think he has the option to do that. Are any of the tech team online to help us?
Maybe I can continue. Yeah.
Well, it's always good to see you, Dr. Mohamed. So
thank you, Professor. I am so sorry if I put any headache or inconvenience. I am so sorry for that. But technology, world of technology, makes us a little bit suffering.
Yes, no, you're right. So I think that the tech team have indicated in some messages to us that they should be able to bring the updated slides very shortly. So apologies for the wait. There is, for those of you who are, you should all be able to see the chat. There is actually a reasonably lively discussion in the chat going on. And I would encourage people to have a read of some of the comments that are in there. I think people are reflecting on several of the talks, particularly around the potential for health technology assessment to be used much more widely across the region and how transferable that might be. There are obviously comments on Professor Sullivan's talk, which relate to trying to advance the agenda that he was talking about. So please have a look in the chat and keep those comments coming, because they will inform the report that comes out at the end of this meeting. But hopefully now we've got your updated talk, Dr. Al-Mansour, so please go ahead.
Thank you very much. Can we go next slide, please? So during my presentation, I will just, briefly talk about the current situation, forces preventing progress in our region, operational research as example, and move finally to recommendation to strengthen universal health coverage research. Next, please. So as a fact, scientific research in Eastern Mediterranean region is facing a critical situation, despite being known as a cadre of civilization and accounting for 5% of our world population. Only 1.5% of scientific papers published every year coming from Eastern Mediterranean region. Next, please. So this graph shows, global share of our region and productivity. Unfortunately, the whole region cannot produce a number of documents and publications, such as one of the countries like Turkey, Singapore, USA, and Norway. So we are behind, we are lagging behind in our region. Next, please. If we go a little bit in depth to look at our medical publication in Eastern Mediterranean region, we found that mainly Egypt and Saudi Arabia, Pakistan, since we are talking about IMRO, are significantly contribute in number of these publications. However, other countries, less and less documented. Next, please. So, as known, in our region, only maybe high-income countries can cover their national research agenda. However, many of the countries in our region depends on the external fund. And in this slide, it shows, the top funding sponsors of research in Eastern Mediterranean region. And so it's obvious that we are rely, in external fund and very good amount of work. Next, please. So I took, just to show our contribution from the region, I took COVID-19 as example. As this was until the last month, the world could produce more than 120,000 publications and documents. Our contribution is about, 102 publications and documents. And it's obvious that we still very low. It's 0.2% of overall publication. Next, please. So if we go to better understand the type of these publication in COVID-19 Eastern Mediterranean region, we found that almost half of these publications are articles, 1/4 letters, and almost 9% as a review. And, so on, we have different modalities. Next, please. So to move to the second item, forces preventing our progress in the region. And here we have common forces that we are sharing with other regions and the globe as well. And we have specific forces for our region, like brain drain, the current conflicts, emergency, political instability, we have concern about data sharing, we have limited resources as well, and we have, unclarity of our research agenda and priority in different gaps. Next, please. So here, I tried, about the scarcity of the resources that we have in Eastern Mediterranean region, and it's obvious that we have tight budget and low rates of expenditure on scientific research. And as known, in developed countries or industrial countries, they spend almost 2 to 4%, and in our countries, we are spending less than 1%. And if we take universities as example, we can see the universities in the region spend 1% of their budget on research, while USA universities, for example, spend 40%. Next, please. So brain drain is very specific to our region. And if we see that almost 30% of total brain drain of developing countries are coming from Eastern Mediterranean countries, and 50% of them are medical staff, and 1/3 almost engineers. 15% of Eastern Mediterranean talents went to Europe and USA, and 1/3 almost of our physicians, 1/3 of physicians working in UK are from Eastern Mediterranean region. Almost half of Eastern Mediterranean students who study abroad do not return to their home countries. And already we know the reasons, it's political instability, absence of environment to conduct research, lack of research facilities, and low quality of research standards, lack of work motivation, incentives, low salary, and so on. Next, please. So we are ignoring that we are writing research and not in our mother language. And I think one of the major challenges that we are facing in the countries is, the absence of the training of scientific writing, or, the scarcity of scientific writing and research, methods. So we advise, we research academic institutions should put more emphasis on training on research conduct, and the scientific writing issue. And maybe, one of the solutions, or we can hire a professional copy editor to read the manuscript before submission of the journal. I think, this is one of the major demands that we are shy to talk about it, but we are facing challenges with the language barrier issue. Next, please. Constraint in getting data. Yes, we have a big issue with we could not, unfortunately, we could not build trust in the past decades, and we are now facing constraints in getting data. Local institutions, universities should focus on developing better archival database to ultimately provide good access to update data for their scholars. Establish data sharing policy. We do not have such a policy at the national level to allow researchers make use of available data. Establish principles of open science and raw data sharing will be most important. Next, please.
I know we had a delayed start, but we'll need you to wrap up in a couple of minutes, to be fair.
Okay, can we skip this, please? Okay. Yes, I am just quoting from Dr. Awad Matariya, where he is, this is one of his slides where he's beautifully and well stated the relationship between universal health coverage and health security. And he nicely stated that health system strengthening is what we do, universal health coverage, and health security, what we want to do. And this is very important, Next, please. And here, I can link the SDG 3, with health security issue, and here, it's a Mediterranean region in collaboration with different countries in the region through the FETP programs. We are working on advancing applied epidemiology in Eastern Mediterranean region through enhancing workforce capacity in applied epidemiology, and through lead and advanced high-quality operational research and supporting of innovative solutions. Next, please. And this is, example of what we are doing in collaboration with ministries of health, mainly conduct operational research projects, studies, field surveys related to various public health working areas, publish, various field works and peer-reviewed journal, and we highly encourage the mini-grant approach to support young scientists from the region. Next, please. These are the examples from what we are trying, to contribute and enrich our publication from our region. Next, please. And, in the past 2 or 3 years, we could contribute, in 75 peer-reviewed publication from different countries and from the Ministry of Health. Mainly, unfortunately, the Ministry of Health, they do not, produce enough publication, although they own the data for different countries. Next, please. So these are in general, about the role of operational or field research, how we can contribute and strengthen the universal health coverage research in Eastern Mediterranean region. And here, just a few words about the recommendation. Research for universal health coverage need national and international commitment to succeed. And I was wondering if we have such a commitment so far or not. Setting up networks of national and global research observatories will provide a mechanism for monitoring, coordinating, sharing information and evidence-based know-how to progress toward universal health coverage. Next, please. Depends on ranging from here, we had very good discussion yesterday about which type of research that we need. I do believe that achieving universal health coverage depends on research ranging from studies of associations to the process of health system operations. There is a particular need for transitional studies that turn existing knowledge into practice in our region. And universal research should be promoted and distributed not only in the academia center, but also in the ministries of health, public health programs and organizations in our region. And we need to keep sight of overarching goal to deliver affordable quality health service and better health for everyone. Next, please. Thank you very much. Thank you.
Thank you very much, Dr. Mohammed. And again, there'll be many questions, I'm sure. Please put them in the chat and we'll come back to them. I think we'll need to move on directly now to Professor Fadi El-Jadali, who's a friend and colleague and is Professor of Health Policy and Systems and Director of the WHO Collaborating Center for Evidence-Informed Policy and Practice at the American University of Beirut. So Fadi, please go ahead. Thank you.
Thank you so much, Mike. Thanks for all the speakers and all the participants. Good morning, good afternoon, depending where you are. There is a lot that has been said, I think, today in this plenary as well as yesterday. So though it makes it even easier, at least for me, to make my intervention. But I just wanted to actually more of the argument that I'm bringing today, that certainly research is very important, but is not sufficient in the context of making change in the UHC agenda. I think over the last decade, we've seen really. Yes, we have to look at some point at the glass half full, not half empty. Many MENA countries, in fact, we've seen significant improvement in health indicators such as life expectancy, at birth, maternal mortality, child mortality. Some good outcome indicators, but still those achievements are really more highly inequitable and still not sustainable. I think and I think Richard and others already mentioned about some of the challenges we're seeing in the region when it comes to serious emergencies and crises, particularly when it comes to how much we host in terms of refugees and displaced population. It was mentioned about the significant burden of the NCD when it comes to outcome and risk factors. In addition to, of course, the total health expenditure per capita in many of the countries that certainly fall short of the global average when we try to compare. In addition to the poverty, and the people are really vulnerable to poverty. So if you look at all those problems, I think there is also some good more of solutions. But I think the solution, the question how to take it into action. We know that when it comes to UHC, we need to certainly improve access to services. Provide better coverage, develop better policies to ensure delivery of high quality and services, making sure that we have patient-centered care. making sure that we're using the information and the analysis to communicate better to influence decision, changing the financial arrangement to provide better equitable care, making sure that we have a qualified, a well-distributed health workforce. So we know a lot of solutions. I think the question is what I want to argue is that this is important, but not sufficient if we don't engage with political forces, if we don't understand the power structure, if we don't understand how we're gonna translate, communicate evidence to influence action. Next slide. So again, I talked a little bit how much, when it comes to SDG, I'm not gonna repeat what has been mentioned. I think the key thing here that we would like to see that certainly the COVID-19 pandemic, and it was mentioned, I think it exposed a lot of inefficiencies in our health and social systems. And at the same time, it showed that what are some of the gaps and dysfunction that exist in the governance, the financial delivery arrangement, as well as implementation. So certainly, MENA region has a great opportunity to start thinking about what would be that fundamental shift in order to more strengthen and more reach toward the UHC target. Next slide. Now, I want to go very briefly. I think that I'm not going to stop a lot of it, but there was some publication that was done by several countries, different teams, including us, when it comes to the use of evidence in policy. We've seen, despite that there is some gaps in research production in the region, still there's more efforts need to be done when it comes to knowledge translation. We've done some work about the use of evidence in policy. We communicated and surveyed researchers, policymakers. Next slide. And we've seen that certainly, part of the most frequently reported barriers to use evidence in policy that sometimes we don't have administrative structures. Still many ministries of health and others lack policy analysis department, limited value sometimes for research evidence. Sometimes the research is not policy relevant, or sometimes the limited funding, lack of training of policymakers. But at the same time, what would be the facilitator? You will see that yes, we need to have research available, but at the same time, we need to communicate better in order to actually influence action. Next slide. There's also work that has been done by AMRO, Dr. Mandil and the team. I think there is a lot of series of publications that actually came out. But one of those is really when we actually survey institutions, significant number of institutions in the region, you will see that, in fact, there is some challenges when it comes to how much institutions are aware of the research priorities, how much researchers are aligning supply and demand, how much we are syncing our production with priorities. When we ask how you are disseminating research, still the most frequent approaches, seminar, conferences, scientific journal, websites, at the same time that there is a limited investment of training being provided to researchers of how to write policy brief, evidence summaries, rapid response, etc. Conduct policy dialogues, and making sure that you influence and engage with political and policy influencers. Next slide. So when it comes to from a K2P, so we are a WHO Paramedic Center for Evidence-Informed Policy and Practice. There's two centers worldwide. There's a McMaster Health Forum and there's K2P, and more hopefully is coming in the region. So the mandate is really to how to work at the interface between science, policy, and politics, and how we can really make sure that the evidence that's being generated is locally applicable, contextualized, but also used for influencing decisions. We have different programs. We don't have a lot of time to actually mention about that, but I wanted to actually talk a little bit about some of the examples we have. Next slide. So this is where what we always look at, that whenever we produce and look at research evidence, we always think about the impact. What impact we would like to achieve as a result of this type of work, whether it's systematic reviews, evidence summary, primary research, etc. What type of impact? And that's why we do what's called backward mapping. So whenever we work on changing laws, legislations, program, we start thinking about, in the ideal case scenario, what type of laws, programs, legislation, decisions that we need to influence, and then we map it backward in order to say, okay, do we need the primary research? Maybe there's a lot of primary research that has been published internationally. We don't need to invest in primary research. Maybe we need to do evidence synthesis. Maybe we need to invest in systematic reviews. Maybe we need to harness the existing systematic reviews. I've seen a lot of research waste, to be honest with you, and some of the duplications really happening, and we could even have a wiser investment of how we're using this type of evidence in order to influence. So we actually we start from priority setting to the type of product we need to produce and take it into knowledge uptake and translation. Next slide. So this is an example we conduct formal and informal priority setting. Sometimes we receive a request from policymakers, okay, I want how we can advance USG agenda, for example, how we can better respond to COVID-19 challenge. Sometimes we get those requests, and sometimes we do formal setting, and also we do a regular priority setting exercises. Next slide. This is an example of some of the things that came out from priority setting. You know, engaging policymakers throughout the process is very important. Political and policymakers. So this is an example about some of the work that we were able to influence as well, the thinking about USG and the implementation at the primary healthcare level. We worked on looking at the barrier facilitator for the essential benefit package within primary care, which is really very important for USG. Also about community-based health insurance scheme. We worked as well with teams from Harvard and George Institute on work related to quality, how to improve quality, safety, and performance management in primary care. And we've done a very good, interesting scoping review, which is published, and we've looked at different policies related to. So all this coming from priorities to inform decision. Next slide.
Fadi, so that we can give the participants at least some time for questions, I'm going to need to ask you to finish in 2 minutes.
Sure. So we do also evidence map just to visualize what we see. Next slide. This is the type of products that we have. It's already all on the website, but these are evidence-based documents of how to translate evidence, how to engage with policymakers from a policy briefing note, rapid response. We have even product for media, how to shape and promote the use of evidence in media. Next slide. So again, different approaches to knowledge uptake activities. We engage and we do deliberative dialogue with different components. Next slide. This is the type of dialogue we bring all the stakeholders, and this is very critical intervention to make sure that the evidence is used at the jumping off point to influence decision. Next slide. This is an example of the rapid response series. We've produced more than 18 evidence-based document, global, regional, and national on COVID-19, and influenced many decisions at different levels. Next slide. This is example how we engage with parliamentarians. When we had a new parliament, we lobbied and we created an advocacy fact sheet to everything that the parliamentarian needs to know about primary healthcare, for example, and USG. Next slide. This is also engaging. So engaging with political forces, but engaging with media is very critical in order to influence decisions. Next slide. This is an example of how we informed the essential health benefit package at the Ministry of Health in Lebanon when it comes to UHC. Next slide. And these are just examples of how we use this framework in order to actually maybe support the work that's being done to improve access to care for Syrian refugees. Next slide. We were able to influence accreditation system when it comes to patient safety goal as a result of this type of approach. Next slide. And this is my last slide. I think the key thing that I think we need to, what I'm trying to say here is that recognizing universal coverage must be achieved, cannot be achieved without evidence, but also evidence and research in itself is not enough. So that's why you need to create that climate to inform and to promote evidence-informed policies. This is very important. That's why my message for researchers, we need to engage better with political forces, understand power system, and ensure and engage with policymakers in a regular fashion. Thank you so much.
Thank you, Fadi. That's fantastic. So I'm grateful to people for being as speedy as they can with their talks. We do have 5 minutes or so for key questions. So we've got a team who'll be monitoring for hands up. But I've also been monitoring the chat and people have been posing questions there. So because we have limited time, I might try and summarize some of those questions that are from the chat and bring them back to our panelists. So if the technical team could allow all of the speakers to come back into the panel, that would be great, so that we can pose a question to them. So one of the questions that seems to be coming from the chat is related particularly for countries that may have, we've seen that there are weaknesses in research capacity and research institutions. So for those countries at the beginning of this journey, maybe I'd like to ask Dr. Al-Ansur and Dr. Muna and Dr. Fadi maybe to give some quick comments of how should people start? How can they start in their country to create the structures that will enable them to do some of this important work and feedback into policy? So Fadi, I can see you on screen. So maybe Fadi, where would you start, or how did you start many years ago in Beirut?
Well, I think one of the things that we've learned, I think it's very important to say that this is important, but what worked is that when you demonstrate the value for this work, I think making really demonstrate to policymakers and politicians the value of this type of work and what that means and how it's really serving their agenda. When we started this work, we created the demand for this work. I mean, it's hardly you will find a policymaker who will call you. Actually, sometimes they don't even know about what you're doing. Sometimes they really, they are not aware that the interesting work is going on in your country or in your institution or your university. We think that when we publish, people will read. The reality is it's much more complex than that. So that's why that engage. So raising the demand and raising their awareness and conducting a capacity development for them and for researchers to do that, and demonstrating. I think providing a demonstration of the value, I think this is the aha moment will come when they say, oh, so now I know that, this is what all this means. Even some people till now, the word knowledge translation, it's not clear for them what that means. What is the meaning where you broker knowledge between evidence, policy, and politics? And so what I would say is that building more capacity, creating more demand, and making sure that you demonstrate the value of this work.
Thank you, Fadi. That's fantastic. So don't be frightened to go and knock on the door of your policymaker and explain what you do. But maybe Dr. Muna, also, how did Tunisia get going? I'll come to you, Dr. Mohamed.
Thank you, Dr. Mike. So actually, our organization, when it started in the very beginning, it was mainly aimed for accreditation. So it started there, but there were, I would say in the very beginning, it was not really aimed at, working on health technology assessment, working on clinical practice guidelines. But over time, I think that decision makers started over time to realize the importance of this discipline. And I think COVID-19, in a way, got a positive impact on us for this. We have, INEAS has been a lot invested in working on clinical practice guidelines regarding the diagnosis, the treatment, and the management of COVID-19. So it was a sort of platform that gathered, a lot of health professionals in order to write, common guidelines. So Health Technology Assessment Department has been a lot, involved in all what is related to investment decision for COVID-19. So I think this kind of crisis was in some way an opportunity to make decision makers, I would say, more aware of the importance of getting this kinds of institution in order to go out, more quickly from a crisis such as this. But I think, realizing the impact of the work that we can do, it takes a lot of time. So actually, economic analysis or, performing systematic reviews in order to inform decision making is something new, in our settings. But I think that the influence of our institution and, the impact on decision making is growing really very optimistic for the future. So
great,
and I saw, in the chat that a lot of people told me, okay, you are working mainly, seems like you are working mainly on drugs, but we feel like, equipment, medical devices, health strategies, and I agree perfectly with that. And actually, it is also in the scope of our organization. I had just a lot of time, to speak about all the work done in this. But I think that we have to start somewhere. And we have to follow in some way.
Okay, can I stop you there, because I do want to bring the other panelists in.
Yeah.
But I think we're hearing again, create demand, engage, and keep going, persist. But Dr. Mohamed, any quick comments from you on this issue? How do these
I think we need to start. From my point of view, that we also need to start with bridging the gap between academia and other institutions like ministries of health, like governments, we cannot keep, the research only for academia. We need to work together. We need the culture of teamwork to achieve, the agenda of universal health coverage. Thank you.
Thank you very much. And I think you've seen people, and I'm sure you know others who obviously have achieved this, have had success, and I'm sure they would be happy to give further lessons to you. And maybe Dr. Hanad, your institution would also help them with those engagement functions if they need to. Can I quickly take another area that has come up in the chat before we have to close? So there was an issue of, I guess, engaging more with communities or the front line and bringing their issues up into research, and maybe that will result in having different paradigms, non-Western paradigms. And I'm interested in, for Dr. Tasneem, in what insights or lessons you feel you might have learned about that process, and then I'll hand over to you, Richard, maybe to give us some sense of what's important or how that can be done.
From my experience, working with the community would require also empowering the community. And to empower the community, we need to speak with them with the same language. Unfortunately, the language we generated from research or academic institution, or even by policymakers, is not well understood or accessible by the community. So first lesson we learned is the importance of speaking the same language with the community. Moreover, we need to understand that community resilience is something that is being built over time, similar to immunity. So we could see in Central Asia, as the community have been subjected to a number of challenges, human-made or nature, like earthquakes and other different of emergencies, we can see that their resilience was building over time. So we need to take this into consideration, but we shouldn't be abusing this. So we should respect that the community endured a lot of pain over time that could make them more resilient, but also made them more dissatisfied with many actions that would be perceived by the government as optimum. Last but not least, the importance of the role of NGOs. Thank you.
Thank you very much. I think useful lessons. Maybe I'll pass to you, Richard, for some brief comments, then I'll come to you, Dina, for a very quick comment at the end. So, Richard?
Yes, I think within academia particularly, there's often a big tension between the kind of research that academics want to do in order to achieve high impact publications and be published in the right journals versus the sort of research that's actually connected to the local context, which obviously often does not enjoy high impact publications. And there's a real tension between those, and that the connectivity between individual researchers, let's say my colleagues like Rita Jacoman, looking at mental health in Birze in Ramallah, will go into only very small niche journals, and that can be a real tension there. But I think that's a really missing aspect. And I saw Dr. Badra mentioning about the social sciences. I think we're still suffering, as Fadi said, from the two cultures problem, which is a really hard biomedical approach to life without understanding the importance of anthropology, social policy, historical aspects. So we talk about mixed methods, but I don't often think we really practice that, and stuff that's actually really connected to the ground, to the NGOs, to the communities in which these studies are being done. But I think the biggest tension, to be honest with you, is around the academic Western publication approach to this. Thank you.
Thank you very much. And Dina, again, I'll pass to you for a quick comment, and then Maha, I'll come back to you as we close the session.
Yeah, I thank you very much for all the presenters for this very important and that highlighted across the spectrum of the problems that we're having. But I would like to highlight just 2 points. I think I agree with it completely with you, Richard, that there is this implementation science, a whole field that we are not really approaching accurately. We are, it's even discouraged in our communities, in our policy, among our policymakers. because they don't understand it. They don't understand what value it gives to the implementation of the services, and this is the type of research that would actually make more impact probably than other empirical research. And Dr. Fahad, I have a very good question for you. In your research, you have looked at the political wellness across the region, but have you noticed any differences? And what are these differences, if you have seen, between the political powers in different parts of the region? Thank you.
So Fadi, you'll have to keep this answer very short, which will be difficult. Go ahead.
No, I think we can definitely have a lot to say about that. But certainly, what I'm trying to say that understanding the power and the political system is very critical at the country level, not at the region level. We cannot look at all the countries alike in the same MENA region, and this is really very important. And I just mentioned in the chat box that many of the the political, the economic, the resource distribution decisions, these are made outside the health sector. It's not in the health sector. So when we want to influence decision, when we want different sectors to look at health as an outcome, as part of a social distribution, we need to engage with different sectors, but we need to understand how politics and power works. We need to understand the issue about accountability. We need to understand issues about corruption. We have a lot of issues when it comes to corruption in health system, and we need to understand that world as well. But yes, definitely my message is not that we need to look at all the health system in the MENA region or all the political systems. We know they have with a lot of differences. In fact, we're now doing analysis or looking at all the countries in the region to see how they responded to COVID-19. And we wanted to link their responses with how the political system and the decision-making process works. So we can really better understand how decisions, how policies are being made.
Thank you very much, Fadi. And we will have to bring this session to a close because we've run a little bit late. But it's just really for us to thank the fantastic speakers. I think you all did an amazing job of bringing together and highlighting a whole set of issues. And I'd also like to thank the participants for contributing to such an active chat. This webinar will be, well, hopefully is being watched now. There's a recording that will be made available. So if it's useful to you to share it with others at some point, please do. And how that can be done will be circulated. But I'd like to thank everybody and now pass back to Dr. Maha, who I think will lead us into the next session. So thank you, everybody.
Thank you very much. Thank you very much for the excellent presentations, for the points that have been brought up. For it's a learning experience, and what is really amazing is that sometimes we understand that we know it all, but we never step back to do the real assessment of how we need to move forward or what needs to be done in order to have this leadership part that would guide us into the follow-up. So, can you hear me?
According to predefined benchmarking criteria required.
Can you hear me?
The reviews will be blinded to the site, and shall I put experience?
Pardon?
The reviews will be blinded to the site and assessment.
Cameras and unmute yourselves.
So can you hear me now?
Yeah.
Yes, Dr. Maha, we can hear you.
Okay, so now we can move to the breakout group presentations that were undertaken yesterday, and we're asking the chairs of the three groups to do this final presentation, and we're giving each chair or the presenter 10 minutes, and then each was going to be followed by a 5-minute commentary if needs to be done. So I'm asking Dr. El-Sheikh Badr now to present the models of care, advancing the models of care for the quality UHC in group 1. So, Doctor, and you have 10 minutes, please, Dr. El-Sheikh.
Thank you, Professor Maha. In fact, we have had very dynamic and insightful deliberations of the group yesterday, and we came up with a summary, which I'm going to present. Next slide. So in terms of the current situation in relation to universal health coverage research in the area of models of care, we came up with the conclusion that there is an overall lack of research in this area in the region. Although there are some research efforts that are emerging in the context of COVID-19, but much of this research is observed to be led by academia and academic institutions with less participation from the service side. And also some of the research or reporting is led by some consultancy firms, and that might not always be rigorous. Also, there are newly emerging collaborative research projects, as we have heard from the experience from some countries. Next slide. So in terms of the barriers and challenges, of course, most of these were reiterated during this workshop, including the issues around funding, issues around perceptions, as this area of research isn't perceived as a priority area. Then also we have the issues with policymakers not fully understanding the importance of research in this area and lack of implementation, as has been pointed also. Next. Also, in terms of priorities, there are other areas that are seen more of a priority. For example, COVID-19 is dominating. We also observe the diversity of populations within regions that need to be taken into consideration. And the group observed that there is sometimes a focus on a specific group, for example, of refugees. Also, the lack of collaboration, whether it be between public and private sector or between health services and academia, is one of the barriers. And as I mentioned, the area wasn't overall seen as a priority. And also, there was no reflective or diverse or research reflecting on diverse populations within the region. Next. Also, to add to the challenges, there is the issue of low quality of data and the problems of access to information, which is mostly regarded as security, and therefore the access is difficult in most cases. And also, we have the overarching challenge of the lack of capacity, adequate capacity for research. And then the value of research to policymakers is another challenge, and also the political dimensions that are happening in ministries of health, for example, and elsewhere, and also the aspect that universal health coverage is not fully understood actually by health providers, and I would say also even within academic terrains. And there is also the overarching challenge of instability and political turmoil in the MENA region. Next. Current efforts, successes, and learnings, there are not many in the region, and the group observed that they are mostly small and not a large scale, for example, not at a national level, and there are some small pilots that offer success, and these could be scaled up. Also, much of the research is observed to be focused on marginalized populations, and there are some emerging collaborations that carry promise in the region, although they are of not much large scale, but they are promising. Next. In terms of mechanisms, the group doesn't observe much of availability of mechanisms in this area for scaling up research on universal health coverage, as fragmentation is prevailing. fragmentation between different institutions and between different types of systems. Effective mechanisms are still hampered also by the low priority for research in general, which we see in the region, and that was indicated in some presentations, and the lack of full understanding of universal health coverage concept itself. Next. In terms of key priorities, the group could identify a few like endorsement and advocacy of research into universal health coverage at the strategic levels, including ministries of health and professional associations. Then also operational definitions for universal health coverage is seen to be important. Agreement of minimum standards for research, and involving economists in the design of research, or extending into the social sciences and their engagement into the research, together with the biomedical dimension. Assess existing health technology to inform research, and we have listened to presentations on that. Strengthening capacity for research design and implementation, and then creation of regional research groups. Those are all some of the key priorities that were thought relevant by the group. Next. And in terms of identifying some of the research questions, the group indicated few of those, including discussing the impact of humanitarian intervention on healthcare, examples, the cases of NCDs and HIV and others. The need to look at research in the 10 or unstable countries in the region. As we know, our region is quite diverse, so we cannot generalize. We need to really devise strategies for different sets of countries. And then how can we bring care to different populations? This has been seen as important. And then the issue of vulnerability of people, which impact their health needs. And this has got a social and political dimension that has been pointed out. Next. Okay. So these are the contributions of the group on the models of care, and if there is any things to be indicated by the group members, I think there is some time that allowed for that. Thank you.
So I can see Zikra. Are you commenting? Thank you, Dr. Sheikh, for this elaborative, comprehensive points for discussion that we can discuss later on. And I think, Zikra, you have something to add?
Well, yes, I'm delighted to present the Group 2 discussion of yesterday. And shall I start?
5 minutes, okay?
10 minutes?
5 minutes.
Wow. Okay, I thought it's 10 minutes, but yeah. Okay, thank you for the fruitful discussion that have been running yesterday with the Group 2, and to Dr. Mender for guiding and sharing the session. As you know, there are a lot of commonalities actually I can notice between the...
No, just a second, Zikra. No, I thought that there are some comments on Dr. El Sheikh's group.
Oh, no, thank you, not yet.
So Fern, do we have any commentary? So I think we don't have much comments. So okay, then we're moving ahead. Zikra, thank you very much for the second working group. And Zikra is from Yemen. She's presenting for advancing the strengthening measurement and performance of quality adjusted universal health coverage. You have 10 minutes. Yes, I'm sorry.
Well, thank you. Now I can breathe properly. Well, as I said, of course, thank you very much for giving me this chance. In regards to the Group 2, I think we have to start by saying that to respond to the 5 questions, we have to realize very well that the regions is composed of extremely heterogeneous setting and context, ranging from extremely high income with cutting-edge technology to middle income with infectious diseases and NCDs, and to low income where no access even to safe water and sanitation.
We are not, of course, forgetting to include the fragile or very, very complicated war settings where the state is fragmented and lacks legitimacy and governance. So to respond to the first question, the universal health coverage is having variant and different expressed political commitment towards achieving universal health coverage by 2030. And also variable, measurable UHC targets with no legislations in some countries to UHC. Although there is a variant, also application of national or development of national health sector plans, but if even available, it's fragmented in fragile setting. Second,
use the slides.
Yes.
Okay.
So the facts about the region that due to political instability and conflict, there is a difficulty in setting and achieving long-term goals for research. And this is quite obvious from the variant region. If there is research, it's very little on UHC, including evaluation of quality. And we are stressing in this group on the quality of research and quality of care provided, as well as the quality of the research that have been implemented in the region. Fragile conflict and violent populations are often moving within countries and outside countries even, making research more complex on the long term. The perception of quality is not harmonized across different actors, leading to different implications at the field level. There is lack of quality benchmark related to humanitarian context. So the role of policymakers do not always understand or consult or even translate the research into policies, and vice versa. Actually, the other group or the other stakeholders like academia, they do not focus on reaching the policymakers and explaining the outcome of their researches very simply to the policymakers. Next slide, please. In regards or in terms to barriers and challenges, there are a heterogeneous list of barriers and challenges based on the heterogeneity of the region. Limited access to data, as was mentioned by Group 1. Also limited and no data sharing, whether it's intra or intersectoral and even between the countries. It's very, very limited and not focused on. The matter of standardization way of presenting, protecting, and benchmarking that data in spite of WHO guidance and other institutions is also lacking. The COVID-19 and its implications on other essential health areas was obvious and have been still obvious on funding. And is, as we see, it's diverting the fund for the COVID-19, especially the tertiary levels, from the MOH and NGOs. The conversation on the UHC and quality of research is really lacking among the humanitarian organizations themselves. And there is an obvious disconnection between the MOH and the multilateral agencies. Another important barrier is the perception of quality is not harmonized itself across different actors, leading to different implications at the field level. Next slide, please. Additional barriers also, it's the matter of inequality, inequity, and lack of social inclusions of certain ethnic groups or certain groups of in the fragile states, like the IDPs, the refugees, in terms of quality of care, and that makes research very, very difficult in such settings. The affordability of care also varies across region, as was mentioned in the previous presenters of this morning, which is quite in line with the recommendations of I think the 3 groups. This is actually exacerbated in the regions of conflict and war-torn countries, and makes planning for care more complex on the long term, and even implicate the priorities and make priorities changing along the way. Perception of research on quality varies. So how strong the research is, we follow on standardized basis. For example, implementation research, the impact of an intervention, the quality of the research, and the research on quality need further work and further standardization. Humanitarian versus development. Now we are in this setting, and the region is focusing on humanitarian, on those volatile areas more than development. So that changed the quality domains. So perception differ in areas of conflict and non-conflict settings. So life-saving is more important than the efficiency and the quality of health services provision. Physical and mental well-being of healthcare workers, it's quite obvious and it's missing. And we have an example of the infection prevention control measures on health workers, and even the safety, physical safety of health workers. Next slide, please. As Professor Richard mentioned this, and Professor Jardali, we have to look at the at the filled half glass. So we still, having said all that barriers and challenges, we still have some success stories. And I have the privilege to mention one success story in the most humanitarian context of Yemen, which was one of the impact evaluation studies or researches on one of the programs supported by donors like the World Bank and the End Fund. And due to the strong partnerships between the relevant stakeholders, given also the strong political commitment of the Ministry of Health and the involvement of the academia and the community leaders, even with the community sensitization, with technical agencies like the Schistosomiasis Control Initiative at the Imperial College of London, that I was part of it at that time, it leads to a reduction in the prevalence of the intensity and infection of the infection in just 4 years of the program life. So this is one of the most important success stories, and I'm quite sure that we still have a lot of success story if we want to focus on and share experiences and imitate such stories. Next, please. In regards to key priorities and opportunities, actually the matter of standardization again, and the benchmarking of data in a localized setting and among countries, and how can standards be adjusted to take into account local variances in population, the migrant population, the IDPs, the marginalized communities. We need to invest on disabilities and mental health research, and we need to focus on collaboration on the role of private sector itself, and we have a very great example during the COVID-19, how private sector rescued some fragile context from providing the sophisticated equipments and measures to
you have 2 more minutes to go,
okay.
So you have to just...
Those are also very, very important, parliamentarians and other stakeholders in the new HE. Evaluation of minimal service package is also very important, driven by WHO. But its effectiveness is needed to be examined. Next, please. The role of primary healthcare in the management of crisis in the CFVs, centralization versus decentralization. We have to focus on family health and primary healthcare on the decentralized level rather than to reach the centralized level, which is the tertiary healthcare centers, for not to waste resources. COVID-19 disruption, its implication on human resources and health workforce also, the death of health workforce and the divergence of their work. The out-of-pocket and health expenditures by different population groups during the conflict is impacting the achievement of UHC. World Bank, WHO have created a momentum on health system and dynamic needs assessment, and this is also a lesson to learn and to continue on such manner. Next, please. Mechanism. In terms of mechanism, research can provide measurement and strengthen data system to enable prioritization and endorsement by government ministries and policymakers, and that make a platform for them. Research can stress on continuum of care, on prevention and palliative care rather than curative measures. And research also can provide an evidence to reduce the gap in terms of accountability and affordability and equity. Research needs to address population needs and to make programs on people-centered approach rather than search for their preferences and needs. Next, please. System approach is very much important. Create movement that advocate for putting research from civil societies and build on local research initiatives and capacities. Next, please. And I think I'm done. Thank you very much for listening.
Thank you very much, Zikra. And now, the floor is open. If any of the groups would like to have comments, or any of the participants would like to pose a question, so we can just do this now. If you raise your hands in the chat box. Any questions? Any comments? So I have a question, Yani, and it's always, it always comes when we're talking about research quality, and it is the quality of the research itself, but as well as you were mentioning the data and the data acquisition. Sometimes it does not require research, rather than you need to have an information system that regularly is able to function to collect data and then to translate it into whatever indices or indicators that are needed. So we need at a certain point to differentiate between research that is needed to answer research questions and research or data collections that are needed in order to monitor or to, for a continuous or sustained fashion. So this could be like a systematized mechanism that has to be there. So we need to have both systems as well, I think. I'm just asking, Zikra.
I think it's a comment more than an asking, and you are the most knowledgeable person in this area. So I think, yes, I agree with you. Researchers even needs to be presented to practice and to be simply presented to the community and to the policy makers. So yeah, I agree totally with you, and I think you are right in what you have provided. And I hope if my colleagues have also some comments on response to your question, I would be delighted to hear it as well.
Yes, I was going to emphasize that I totally agree on the point. There is two different items between collecting the data systematically, which we do lack, and between answering a research question. And we do have a gap in both of them. And both of them need to have a systemized approach in order to gather the data and for dissemination also, and to put plans in order to act upon that. So we lack in both of them, and we need research in both of them. Research to have a systemized way to gather and implement and disseminate the data, because we don't have such a thing. And we were discussing that yesterday, that we need to have something like a multi-central research in order to understand the contextual factors affecting that type of research.
Excellent. So we're getting back to the issue of health system strengthening. How to strengthen the systems that you have at hand in order to be able to function, to provide, and this needs actual assessment and research to understand, to start up and understand where we are, where do we stand, and the end point. So thank you very much. I don't think we have any more questions or comments. And now I'm calling Dr. Lubna. Dr. Lubna to present, the supporting evidence-based knowledge translation for quality universal health coverage.
Okay, thank you very much, Prof. Maha. And yes, I would like to start, although I probably have very little time left, I would start by thanking the organizers, the Academy of Scientific Research and Technology, Egypt, and the Academy of Medical Sciences, UK, as well as Global Challenges Research Fund. And as you correctly mentioned, we are talking about supporting evidence-based knowledge translation for quality UHC. And for that, we have defined evidence as being both research evidence and data evidence as well. The participants were fantastic. It was a team that is multinational, multidisciplinary, and with diverse skills and experiences. And although half of them of those expected have attended, we had a wonderful and a very rich discussion. With the aim of exploring the role of research and data evidence in mapping facilitators and barriers to effective knowledge translation, and the role of evidence and suggesting mechanisms, strategies, policies for realizing UHC in the MENA region, with special emphasis on fragile and conflict-affected states and countries. Can I have the next slide, please? We've attempted to do so by addressing a number of questions. So the first question was addressing the landscape and the current state of affairs in the MENA region in terms of evidence generation, updating, prioritizing, and the relation of that into decision making. And we could see that there is a difference between the perspective of policymakers and researchers, their aims of research. They tend to focus more on treatments and illnesses and specific successes in relation to that rather than on public health. And that is probably related to the way of identifying and talking and advocating their successes, rather than when it is about public health, it's difficult to say what they have succeeded in. Research is generated in a disparate fashion. I wouldn't say haphazard, but it's not coordinated in a way, and it's not done in a manner that is able, that enable others to compare the outcomes of those research. So there is lack of communication between groups and coordination. Research priorities are not necessarily based on data or essential public health functions, and not all players or stakeholders are involved in research generation, adaptation, or implementation. And research is under-resourced by governmental and professional societies, and that's this is something that an agony that we all have, and unfortunately the industry is widely featuring in funding many of the ongoing national and subnational research, or probably even multinational. Next, please. What does the existing research say about barriers and challenges? It says a lot. There are problems with finding population-based data, and when it does exist, it's not updated or checked, and it doesn't have the equity lens that is important. For example, data is often considered at national level, but it doesn't allow for the vulnerable populations to be identified and targeted. And also data is not standardized, making it hard to compare implications of research between regions. Not all health indicators are produced within each region. Many are missing. And the root causes of issues are not always identified and understood for an appropriate solution or action to be implemented. Next, please. So progress is slowed by research conceptualization among different stakeholders. Setting health research priorities is not necessarily done via a systematic approach. There is lack of access to valid data and research evidence, absence of data standardization, limited individual and institutional capacity for research, and there is lack of networking and sharing, lack of coordination among players and relevant stakeholders. Next, please. So how can the research agenda be advanced to support a broad range of issues? And we've just listed some of the potential stakeholders. Well, the importance of primary health care being the cornerstone for improving research and improving healthcare and realizing UHC cannot be overemphasized. But primary healthcare can be used, in addition to what we all know, to raise the voice of the community and reflect, or they can be the representative of the society for the research community. There is a need to develop physical institutes and think tanks to better enable networking and communication. And this will enable improving the horizontal communication between policymakers and funders and the researchers, and it will help the vertical communication between the vertical is between policymakers and the end users and researchers in the middle, linking up and down, and the horizontal communication between researchers in different regions, in different countries, working together and implementing the outcome of their research together. And multi-country experiences would support policymakers at regional levels and would give the context the policymakers would like. Next, please. Academia, how can it help? Research should focus on outcomes and successes that would give policymakers the tangible results that they can use. So the results should be progressive in the sense of having day-to-day or month-to-month or whatever. So there are small successes in terms of delivering outcomes that people need. So it has to be society-oriented, and it has to have, the outcomes have to have the dollar sign. So in terms of savings, in terms of rationing resources, and so on. So it would help them it will empower the policymakers to support this research. The academic community needs to provide practical and not academic solutions which highlight the potential outcome and consider implementation, standardized data collection, and to improve the transferability of data between countries. Vulnerable populations should be identified, and the relative ease of implementation of policies and programs should be adapted in order and targeted to these needy populations. Next, please. NGOs, their role is crucial, and they are involved in they should be mapped, and we should select the highly specialized to be partners in research, and they can help in terms of data collection, funding, interpretation of data, and the views and opinions of the public. Last slide, please. We thought that we would come up, well, the landscape has been portrayed by so many speakers between yesterday and today, but we thought that if we want to select one thing, it didn't turn out to be one thing, it's a list of 4 things, and we were supposed to be voting on this, but we didn't have time to do this. But what could be the main messages or the main starting points for policymakers and researchers and all stakeholders? These are the 4 things. Develop valid data system, which has an equity lens, establish an institute of health or health research in each region of the MENA, in the MENA region, to connect with policymakers and connect with other stakeholders in terms of priority setting, capacity buildings, and other matters, and implementation, of course. Improve the transferability of data and research evidence between regions. It's not, we're all alike. We share a lot in common despite the diversity among us and the differences, but at the end there are more commonalities than differences. So it's not possible to come up with research done in each and every country, but we can share our results. And a participatory approach and participatory framework would help in meeting the health resilience. Yes, we've heard about the bigger health system rather than healthcare system, and that we are in need of a resilient health system, and the participatory approach when it comes to research and its implementation and data implementation is vitally important. Thank you very much. And I hope, I'm sure probably our colleagues who were in that group would like to add something.
Do we have, thank you, Dr. Lubna, Professor Lubna, do we have someone from the group? Third group?
I don't think there are any questions in the chat.
Okay, so, okay, thank you very much. Thank you very much for the presentation. I have a comment for you, Dr. Lubna, and thank you for mentioning it. Yes, we have commonalities across the region, but we have the differences as well. So we have to make use of the tools that we have to make use of whatever resources are there, given our situation, very special situation in the region, in order to advance the research agenda and its utilization, maybe through platforms, maybe through knowledge hubs, maybe, you have the structures that is able to just, in a way, make use of the available resources. But in a way, I was just thinking, as you were just saying your presenting, so what type of research are we talking about? We need the basic research and we need the other research. We need this health system research. So how can you put the balance, to bring the balance to the needed research? This is an issue. And I think it's an issue and it's a challenge at the same time, just to put in the balance to whatever is needed. And you cannot do so unless we know what are the priorities that are needed. So we need to have priority setting as well. So it's a comment and a question. It's okay.
Okay, so priority setting, as you mentioned, is important, but whether it starts after mapping what we have and identifying the gaps, or whether it starts first and then we go backwards into other gaps. But we thought that these could be the four things, could be the priority things that are catchy for decision makers and would have an impact. But I agree that we need the landscape to be appropriately assessed and identifying the gaps in a systematic way.
Thank you very much. So, Mike, do you have any comments? Mike?
Thank you. Yes, I've really enjoyed listening to the group's presentations. And I think we'll be coming on now to a wider discussion across those participants and panelists that are with us. So I would, if people do have a chance to put up their hand, I hope we'll be able to call on them to actually ask their question and provoke some discussion, or if you want to make a comment, please do that. And there are some things coming through in the chat. But as we get this discussion going, Dr. Maha, I've actually got a question for you because you were a minister of health and population in a very large and complex country in the region. What do you wish researchers had done for you when you were in that role? What do you now look back on and think, if only the research community had helped me with this? What would be your thoughts and reflections?
Okay, I want to refer to you that I come from a public health background, a totally different background than any of the ministers who are in this position. So the research, the data part is really integral part of the thinking of people who are public health professionals. I came at a time where there was much turmoil in the post revolution, and at that time I wish I had researchers sitting with me on the table, supporting me with data that would really support the decision making in many of the issues, because we were leading in several ways, in the development part, in supporting the normal health services, expanding them in a way for health and development, and at the same time reacting to things that are happening at the same time. So honestly, to be very honest with you, I had all the support from the international organizations to support the research that is needed. I had researchers and technical office that were supporting me with rapid, as you would call them, not systematized research, but rapid research for to support the rapid data that is really needed to support decisions that are taken. And at the same time, we were able for the normal and the regular work to be done, we were able to initiate researches, implementation research, pilot testing, and white papers that would support the strategy. But first of all, we had in place a strategy on the national level for the Ministry of Health, for research, for prioritization, and for actions that were needed. And it was continued after my term. So I mean, research was an integral part of at the time I was there.
That's fascinating, and I think obviously you did enter that role with a huge understanding already of public health, so you had a better idea of what you
And
wanted.
Mike as well. I was very lucky because at the Ministry of Health there was this health information system that was very properly strong one, properly institutionalized. Having the regular data routinely done and routinely interpreted. So I mean, I did not come at a time when we didn't have the structures. No structures are there, very well implemented and folded within the work of the ministry with participation with other ministries as well, Ministry of for the Foreign Affairs, Ministry of what do you call it, اتصالات, communication, you know what I mean, Ministry of Education. So I mean, this was like health information system with intersectionality with all of the other information systems in the country, and that was really very supportive. So the structures were there, and we were building on it to get what was really needed. I was very lucky, and it still continues to be enlarged as well.
Fantastic, and I'm sure again you'd be happy to share more of your story with people if they want to learn how to engage in policy or what were important lessons. But I've just picked up a couple of things from the chat as I was listening to the group talks, and maybe some of the group chairs or presenters would want to comment. So one of the issues that you may have seen was, so many of you talked about data and data availability and access to data, and one of the questions in the chat was really about data protection and data security and how much that is a challenge currently, maybe for within work that needs to use national data, even if it's in the country, but maybe more particularly for cross-national work. How much of that, how difficult is it to use available data? Is that a real drawback or a real barrier at the moment? I don't know if any of the panelists wants to address that.
Yes, Mike, if I continue here.
Please go ahead.
Yes, I think in some countries of the region, this is evidently a huge challenge. Whether it be at the national level or organizational level, data and information is largely viewed as security. And sometimes that really hampers the exchange of data. We have examples of institutions which treat their own data, which could be public, but they treat it as if you ask, they will not give you the full picture. They will give you only general, and the connotations is that sometimes the dissemination of data might create some political problems or issues to these organizations. So that was more, in my opinion, of a culture that is prevailing in some institutions. When it comes at the level of countries, you also find examples of this. I will just give one example because this is an area which I'm focusing on, the area of migration of health professionals. When you look into the data set or reports that are available from the destination countries in the region, they are never disaggregated. They are never. So it is very difficult for you to really, identify the trends and the size. And we know that internally in those institutions, they are well disaggregated, but they were not made available. So I tend to agree with people who are really observing that there is a major problem in our region with data transparency and data availability in that aspect.
Would anybody else like to make a comment? Yes, Dekra. Sorry, you're muted, Dekra.
Oh, yes, okay.
Go ahead.
No?
Yes, we can hear you.
Yes, yes. Just if you allow me, I like the question that you asked, Dr. Maha, and I will ask it in a different way, actually, because this is the problem in the region and the fragile and non-fragile settings as well. Dr. Maha, you mentioned that you were lucky that when you were a Minister of Health, that you came from a public health background and the situation was stable and you were aware of the needs. But what is your recommendation? Because this is one of the most important requests that we put in our recommendations as groups. What is your recommendation for policymakers and for academia, actually? And you are doing both. How to reach policymakers who comes from clinical background, and purely this is clear in our region. Most of the health ministers are from the clinical background rather than public health, and they are not researchers themselves. What do you think? What is the mechanism? How to reach them? Does the UN can help? I mean, the UN would help, or the academia itself, they have to create a mechanism for that?
Well, may I respond to this? It's not about, no, I said I was lucky. This does not mean that those are coming from the clinical background, they don't know about research or no. When you are in a political position, you have so many forces that really affects the way you need to move, the pace with which you need to move, because there's so much pressure, public pressure, political pressure. You know what I mean? So it's truly different. What we need is to have the structures in place. I need to have a research governing structure in place to support the evidence-based data generation. And I need a mechanism and a communication channels that would support, the utilization of the evidence that is needed. Whatever decisions are made, they have to be built on evidence. You know what I mean? So this is the change of mindset. I'm not talking here in Egypt. No, I'm talking generally speaking. Because yesterday, Jafar was saying it's a change of mindset. And then as well, Awad yesterday mentioned it's a system thinking. So this is a new vision of how you want to take forward things from one place to the other to get the best, most effective, efficient, quality. If you're talking equity, it's a whole bunch of things that are really affecting the system functioning. And I want to tell you one thing, that policies and decisions that are taken outside and done outside the health system markedly affect the health system. So this is a much broader, complex issue. And this is, as we mentioned it with the COVID, and I truly appreciate it, it's the whole government, the whole system that has to be rethought in different directions with a new vision of how to base your evidence on, how to base your decisions on evidence. How, you know what I mean? There are different issues that we need to do. How does research support your decisions? How does research support innovation? How does research come out at the proper time when you need it for decision making? This is a whole issue that needs a governing or governance and leadership for research and health research as well, to lead it in order to be able to get it through the whole phases where you really want it to be in place when needed, and to generate the new knowledge, the innovation, and to keep you on track of what is needed, and to keep you on track of the community's needs as well, the emerging and the increasing needs as we're moving. So it's a whole system approach that we have to think of.
Thanks very much, Dr. Mahan. And I think...
And I'm speaking on the regional level, not necessarily one country vis-a-vis the other, because the contexts are different. So, you know what I mean? I would start by the government and the leadership.
But I think you're making a very good generic point, and sometimes as researchers and as academics, we often complain that the policymakers don't come to us, they don't come to us for advice, and we sit and wait for them to come. Exactly. And maybe we should be much more proactive about going to them, but then we have to listen to what they want. And I'm sure everybody has heard the phrase, never let a good crisis go to waste. If people are being asked to discuss things with ministries of health and policymakers now. Now is the time maybe to begin that engagement for the longer term. But we have to start doing the things that the policymakers want, and I think Fadi was and others are making that point. But Lubna, you had your hand up as well. Maybe you wanted to make a comment. I think you're muted, Lubna.
I just wanted to respond. Okay, I wanted to respond to the question that you raised earlier about data sharing and how, to what extent it's practiced in the MENA region. I think most of the countries are having their data sharing policies. To what extent these policies are translated into practice, I've got no idea. But I know that in many countries, people cannot access even the national reports and their own national data. So, but we're moving towards more of a transparency attitude, and possibly if that was raised as one of the recommendations of this forum, there will be a different attitude. When it comes to within institutions about the randomized control trials and about any other trials which studies that are involving patients, I guess most of the countries would have an IRB national center, and there is an IRB committee in each institution which ensure that in the protocol there is protection for patients' privacy and so on. But most of these IRBs are not empowered. They don't have funds to follow up and see what has happened after that. So that's another problem. So in theory, we have the structure right, but in reality, possibly we don't know what's going on. So that's an area to explore and find out. Thank you.
Thank you very much. And Dr. Maha, I don't know whether we want to, so the group chairs who've made the presentations, there was an effort to try and pull together some common themes across those, which were obviously had to be done in advance, so we haven't been able to revise them with the comments or discussions that we've had this morning. Do you think it's an opportunity to bring up those common themes to see if they provoke some wider discussion?
Yes, and I think they're going to revise and revisit it based on the presentations that we had today and yesterday, and as well with the comments that we're having in the chat box, and as well with. So yes, would you like to say it, or shall I proceed, Mike?
Please go ahead, Dr. Mahan.
So okay, so from the presentations and the themes that came out from the three presentations, these are the common themes that came out, and we thought that we would share it with you. So as for the data challenges, the low quality of the primary data, the lack of data standardization in presenting, protecting, benchmarking data, problems of access. And then we have the lack of networking and sharing, and this was a common theme that has been repeatedly saying during our discussions and in all of the other research discussions that we are having in the past years, and this is due to limited and no data sharing between countries and absent intersectoral sharing. We say that there is lack of networking, but we need to find how can we have this networking and the structures that are needed as well. And then there is the point of the fragmented research and healthcare provision across the region. Definitely we have fragmented research, and definitely we have duplication of researchers. And this is not, the duplication is not really bad, you know what I mean? But the fragmented part is, this is the worrying part. So, and then we move to the lower priority for research in general, and in particular lacking funding for research focused on universal health coverage, primary care and health systems. And if we're talking about the allocation of funds, we need to understand who is responsible for this allocation of funding, what is the process by which we are allocating funding, particularly if we are missing or if we don't have national health research strategy with prioritized issues. And then we have the limited understanding of the universal health coverage and lack of common conceptualization of research and universal health coverage amongst policymakers and healthcare workers. So this is the point I have a concern about, but these are the common themes that came out. And then we have the COVID-19 and the reprioritization of all other areas currently. And definitely the COVID-19 has not only affected the research, it has affected all the functioning of the health systems, all the policies, social, economic. So in a way, this has affected things that are happening. But as Mike said, it is an opportunity now in order to restructure and get things on hand. Next slide, please. So with the priorities part, there are the data, developing valid data, strengthening the data systems and measurement with cross-country collaboration, and improvement of the transferability of data and evidence between regions, creation of regional research groups to address key skills and competencies, and maybe having think tanks, knowledge hubs, and creation of those structures are really very important. And then we have the reducing the intervention gap between the policymakers and academia. Develop a system of resources, commitment, I would add capacity building. And it's not only about policymakers and academia, and as well with the other disciplines that are needed if we're talking about health with its social determinants as well. And then there is the strengthening the capacity for research design and implementation, and strengthen engagement with the research funders, governmental and non-governmental. And as examples, establishment of Institute of Health Research in each area. And then there is the endorsement as a priority, endorsement and advocacy of research into universal health coverage at a strategic level. And this is really very important, that this would come from the WHO, ministers of health, public health associations and alliances, whether on the global, regional, or national levels. And then we have the improving collaboration, role of the private sector, the NGOs, CSOs, connecting other stakeholders, academia, parliamentarians in UHC research. And then there's a need to understand and take into consideration the diversity of the populations within the regions, the vulnerabilities, the migrant populations, the refugees. And I would add here that definitely COVID-19 has exposed and unpacked the vulnerabilities as no other emergency has done. So this is again an opportunity in order to consider this diversity and to consider the needs of understand and consider the needs of those vulnerable groups. Next, please. Other priorities are the national policy for health research with prioritized areas aligning with countries' priorities, and prioritizing universal health coverage as a multidisciplinary research focus. And then we have the priority research areas within UHC and health systems and quality of care. So we need to have this mapping and prioritization exercise. And here we're bringing in all of the disciplines together in order to come up with a priority of the research areas. And then there is building the interdisciplinary competencies as we discovered yesterday, that those not discovered, discussed yesterday, the importance of having health economists, anthropologists, social workers, as well as the academics, non-academics, and from the different disciplines. And in order to, we have to build their competencies and their capacities in order to support the research. And then we need to have accessible data sets. Next, please. So
I think that's all the slides.
Okay, maybe slide number 4 is for any additions from the participants that we need to add or to rethink, rework, maybe.
I think Professor Rawaf had his hand up to contribute.
So, okay, Dr. Salman.
Thank you. Thank you, Dr. Mahan. Thank you very much, everyone, for today's presentation and beautiful, crispy summaries of the working groups. Thank you. I think you mentioned it, Dr. Maha. The reality is we need a clear concept about universal health coverage. I recall vividly Lubna contacted me when she was Assistant Director General, contacted us at Imperial College, said, look, this is the DG policy about the 3 billion. You know, all of you remember about these 3 bubbles, about the 3 billions in terms of 1 billion protected financial protection and 1 billion living healthy life, etc. You know, what does it mean? I mean, a policy was set by WHO, and until today, there is no clarity of what does it mean. And I said to Libna at that time, this is one of the most difficult questions, and unless we have a clear conceptual framework on what do we mean by universal health coverage, because everyone in every country look at it in different way. In the UK, I look at it as a comprehensive healthcare to everyone, free at the time of delivery, full stop. You know, that's certainly not the case in other parts of the world. And that linked to my second point, again, in addressing Lubna challenging questions at that time in her big position at WHO, is that actually, unless we have secondary data, I can generate primary care data for you through research, but unless we have secondary data, we cannot analyze anything in a proper way. I mean, Maha mentioned that Egypt is fantastic with data on multilateral data. This is good news, but we love to see the analysis. You see, sometimes we have data, accumulated data, and we know from our UK experience how challenging analyzing the data which is generated by health services. It's actually the most difficult things and require high-level expertise of researchers, you know, and all of you know in the way we are analyzing this within our institutions in the UK. It's a huge effort, a huge collaborative effort, and supported by the government and the National Institute for Health Research. Thank you.
Thank you, Dr. Salmani. If I may answer to you and to Lubna, and definitely Lubna, you were there at the WHO at a very critical point of putting the 3 billion into place. I was part of this group anyway, and I think that you came out with indicators that very relevant indicators that would support the measurement of, I think, and they are very relevant. If you look at them, and thanks to you, of course, as part of this team. And the issue here now, as we're talking, Dr. Salman, and thank you for mentioning the part of the health information system and the cross intersectorality between the different ministries. The issue is that it's not enough to have an information system and data collection system without having parallel to it, the cadre of people who are able to collect, to interpret, to bring out the evidence. So they go hand in hand, whereby you have those training and capacity building for generating new cadre of specialists and professionals able to interpret and able to bring out the evidence. So it goes hand in hand. When we're talking about health information system, it's not only to have the system, but to have the people who are running, interpreting. So they all go hand in hand, and it's done not only in Egypt, it's done in many countries in the region with differences, of course. I mean, when you have an older system vis-a-vis a newer system that is being in place, but the transformation and the reform is going on in many countries of the region, despite the fragility that Zikra is mentioning. And fragility is not only in Yemen, but in many other countries of the region. You know, not because of the instability, because of the natural disasters, because of the COVID, because of, you know, the turmoil. So the differences are there, but the transformation is being undertaken. So at a certain point, you might have parallel systems at the same time, because you have IDPs, you have refugees, you have asylum seekers, and they need emergency support vis-a-vis the protracted situations in many other countries. So there are different systems that have to be put in place. But the final issue is that we are seeking universal health coverage. We don't want to miss any groups. We don't want to miss the vulnerabilities. We need to protect the vulnerabilities. And in order to do this, as was mentioned, this is a system thinking, how best to provide sustained services in a way that would support the quality, would support the inclusion, would increase the coverage, and would provide the services that are properly needed. And this requires system thinking, but it requires resources as well. And this is an issue in itself. Even it's an issue because the resources are limited and the priorities are very high, while as the demands are increasing. So how to do this? You're using the tools, health technology assessment tools, other guidelines. But the issue is that at the end, we need universal health coverage. So thank you very much. And thank you, Lubna, for the work that you've done with the WHO. Thank you.
Can I make a comment?
Yes, please.
So, sorry, Lubna, yes, please make a very brief comment. We're nearing the close of our time, so if you can just keep it short.
Well, I would like to thank you all and thank Salman in particular for bringing this up. In fact, that was a time when I really wanted to have something solid. It's my academic hat in the WHO. And in fact, I contacted their team because it was a collaborating center, and I've seen that it produced a lot of fantastic efforts and fantastic documents, leading documents. And I've contacted the Ukraine collaboration as well, the EPOC review team, and I've contacted a third group as well in Canada. And in fact, the three groups had a fantastic plan on how to go about defining universal health coverage and measuring universal health coverage and having the indicators. And I really wanted to have different perspectives, so we would really have a real input or a real visualization, conceptualization of the universal health coverage. It didn't work in the WHO, and possibly it can come up as a recommendation from this fantastic workshop that maybe that would be one of the priorities where we contact different leading centers. And we come up with different perspectives, and then we combine or compile them together, and then there will be a real understanding of UHC not only as a concept but as a practical operational definition that would go into measuring, because honestly it cannot be easily measured unless we have just here and there indicators. The other point I wanted to raise is that I think policymakers are not aware of the deficiencies we have in data, because somehow it is modeling and estimates are there to fill in the blanks. And at the end of the day, they don't appreciate well, they know the difference, but when they look at numbers, they wouldn't tell from the spot which are real numbers, original data, and which are models and estimates. And that makes, and that just give a security feeling that would be carried on for ages till somebody brings it up, and then it's not a priority. So I think if there was something about the need for having original data and not just relying on modeled estimates that are handy for every country in the world, even countries that don't have the minimum requirements and the basics of a health information system, but somehow it will be brought to them by leaders in modelings and estimates, then unless we really call it a problem and address it properly, we would continue to have problems with data all over the world, and especially in the MENA region. Thank you very much. Sorry.
I assure you that the work you started is still continuous. We continue to developing the concept and progressing the way how data should be collected at Imperial. Sorry, we are delayed because of COVID, but I assure you soon will be published few things and you will be part of it.
Thank you, Dr. Salman and Dr. Lubna. I think we can carry on this conversation with the different opinions. So, thank you very much for bringing it up now, and I think it's very relevant. And Mike, I think we have come to the end of our session now.
Yes, I think we will have to bring things to a close, but I think there are a few issues that have come up that we need to take back to our those common themes, and I've definitely heard more about data policies, but working with existing health information systems, and it's a relatively unglamorous area of science, which is another problem. It's easier to get a great publication on a model than it is to do a lot of hard work on existing data, original data, from a health system. So again, it comes back to sometimes this issue of the different, as an academic community, we need to start recognizing the value a wider sets of research, perhaps. And I think this goes to the core of universities, particularly for what they actually value. But I think we do have to wrap up. And really, in wrapping up, I've learned so much as somebody who is not that familiar with the MENA region. So it's been fascinating for me. And if I could just make a couple of reflections, I think from what I understand, and I obviously had some appreciation of this already, there's huge diversity in the MENA region, and that poses both as a challenge, but it is also an opportunity, because people are experimenting with different ways of doing things, and there is an opportunity to learn from that. But I've also heard and seen that you have some existing examples of fantastic institutions and strategies and researchers. So it is a glass half full challenge, how to move forward. And I think learning across the region, as it is in my area of East Africa, makes a huge amount of sense. And I think we do need to embrace this issue that's come up many times of the need to be interdisciplinary, which means actually engaging with other other scientists beyond the medical and even beyond the public health sphere. And so I've learned that from my own perspective as representing the Academy of Medical Sciences, where we're by definition, therefore, rather dominated by medical people. We need to be much more open to, and I know that the Academy in the UK does link, for example, with the other academies for the humanities, for engineering, and for other forms of science. So I think it's about, for us in the UK as well, it's about broadening our connections and networks as we try and tackle some of these really huge challenges. I'd also quickly like to thank those the group chairs or the group presenters, Dr. Bader, Dr. Decker, and Professor Lubna, for their great summaries and contributions. But I'll pass back maybe to Maha for some final remarks, but just on behalf of the Academy from the UK end, it's been a privilege working with everybody, the steering committee over these last weeks, and then the participants and panelists in these last 2 days. And we hope to progress to helping develop some output from this, but we're clear that that output needs to be led and directed in terms of its content from the participants and from the panelists. So I'll pass to you, Maha, with my great thanks and wishing everybody stays safe and enjoys what for us in Western Europe is obviously our Christmas season. I hope you have some peace and prosperity in the next weeks and years. Thank you, Maha.
Well, thank you very much, Mike, and thank you very much for very fruitful, honestly, very fruitful 2 days. Although very short, we wish it would have extended much. And we're very thankful to each and everyone who helped in the preparation, in the organization of this workshop, webinar. And thanks, of course, for the presenters, for the steering committee. I can't thank you enough, and for the comments that just came up with the discussions, fruitful discussion. You know what I mean? It's like brainstorming, and it's like paving the way for how things could go ahead. I was just talking with Lubna yesterday, and it was really amazing that we do not lack the cadre of the professionals here in the region. We can make it, and we can do it, and it's really an honor to be part of this professional group, you know what I mean, going ahead further. Definitely we would thank you for the Academy of the Medical Sciences, and definitely I'm not in a position to speak on behalf of the Egyptian ASRT, but definitely they would in a way support this work with together with the head of the Egyptian Academy of the Science and Research and Technology. I think there is much opportunities for work and to take this work forward in support of the research and in support of health system strengthening and universal health coverage in the region. I thank each and every one of you. It was a learning experience. I'm very happy to be part of these 2 days. Thank you all from all regions and from all countries in the region. So thanks you, and hopefully we can, after we just draft the report, we can take it into the follow-up steps and not just stop at the recommendations, to follow it up, and we see how we can follow it up in order to support the agenda, the needed agenda. And this is the opportunity for us to start it, and we can do it. It can take much work, but the entry points are there, and we can just support its institutionalization with a different context, of course, in the region. So thank you very much, Mike. Thank you, friend. Thank you all for everything. It was really very fruitful, and thank you.
Thank you.
very
And
much.
you'll give us some closing, if there's any practical things or notice about follow-up.
Yeah, thank you very much, Mike and Maha. So just to add, thank you all again to everyone for joining. As mentioned, we've recorded the session today, so that will be available on our website if you want to share that amongst your network. So I'll circulate the link following the meeting. We'll also circulate the presentations from all of the breakout groups, and with permission from the speakers, we'll circulate their slides as well. And along with that, we'll send you a feedback evaluation form. So please do fill that out, because that helps us to improve our workshops as we go along. And finally, just to highlight, as Mike just said, we'll be working on a summary draft of the report, and we'll share that with you all after that has been published, and you can share that amongst your networks. That would be great. We'll save everything that's been captured in the chat today. I know there was much discussion in there, so anything that's come through there we'll capture to feed into that report. And any further comments, please do send those across after the meeting via email, and we'll capture those too. That's all from me, but just to say thank you so much all again for joining, and enjoy your afternoons and evenings wherever you are.
Thank you.
Thank you. Thank you very much.
Thank you very much.
Thank you, everybody. Such a pleasure to meet you.
Thank you.
Nice meeting you all. Bye-bye.
And thank you, Dr. Sullivan, for bringing the overcoming the knowledge subjugation. So thank you. First time to hear it, but it's really relevant. So thank you very much.
Yeah.
I've written it.
Bye.
Bye-bye.
Okay.
Okay, thank you.
Thank you all. Bye-bye.
Nice meeting you, Professor. Rawab.
Okay. Yeah.